How to do that? Screen recording. Let's see here. Share screen. Preferences, security, and
yeah, they let you. I mean, it's so good.
Ah.
Coming forward.
Be right back.
Now we can see your slides.
Just let me know.
Sure.
Maybe now's good.
Sure. I think we can start. I'm just gonna briefly introduce you to our speakers. So good morning, everyone. Today we have the honor of having Dr. Harter as a speaker for our ground rounds. So Dr. Harter comes from New York University. He's the residency program director and chief at the Division of Pediatric Neurosurgery at NYU Langone. He graduated from Georgetown University School of Medicine and completed his residency in neurosurgery at University of Maryland, and then completed his fellowship in pediatric neurosurgery at Children's Memorial Hospital. His clinical focus includes minimally invasive and endoscopic approach for children and adults. And his clinical research consists of co-authoring more than 100 articles, and he has more than 28 years of clinical experience. Now we're honored to have him to teach us directly about the management of the colloid cyst, and I welcome Dr. Harter to start.
Thank you very much. I appreciate the opportunity to meet the crowd and talk. I'd like to start off by giving you my contact information if you have any patients that have questions about, or if I can help any of you in any way in the future, I'm more than happy to do that. So please consider us a local resource, here to help. So I'm going to talk about the colloid cyst, which is an interesting neurosurgical problem. Oh, let me try to go here. Okay, good. It's interesting because it's a benign lesion and it can occur in young patients, but it's also potentially fatal, and it really represents a unique psychology to address this problem. And from a neurosurgical standpoint, it does have some interesting technical challenges in decision making. I'll go over kind of the standard talk format of embryology, pathology, epidemiology, a little bit of history, clinical presentation, imaging, decision making, and techniques. And again, I apologize if I go a little quickly because I do have a case that's happening. So I'm coming to you live from the OR. So the embryology of the region that we're talking about, it is quite complex. So we're third ventricle, and there are a lot of embryologic things happening. A lot of things have to disconnect and find their way to where they need to be. And the colloid cyst is a example of when that goes slightly wrong. So these are epithelial line cysts, similar to other cysts. And when we look at them histologically, they most closely resemble respiratory epithelium. And that makes sense because they're filled with kind of a mucinous material. They can be only a couple millimeters in size, up to many centimeters in size, but usually about a centimeter. Round or ovoid, and they can be quite solid or quite cystic. So it can be very different. Although it's the same pathology, there really is a spectrum of what we find during surgery. Usually there's a fibrous outer layer and an inner epithelial layer with its kind of secretory border towards the center of the cyst. That's why it gets bigger over time usually. And it's interesting because it only occurs really in one location, almost always in the anterior third ventricle. Rarely they can move, but that's really an exceptional circumstance. And I can't say that I've seen it. This is just what the histology is. So colloid cysts usually EMA and cytokeratin positive. This is what they look like. So you have this secretory border with fibrous external surface, and this is mucinous material that you can see. And this is just some more immunohistology. So they account for a small number of intracranial tumors, probably about 1%, but of interventricular masses, more, 15%. So very, very uncommon. So based on population studies from Finland, they estimate about 3 cases per million per year. So not that common, but as a neurosurgeon, we're kind of the end of the funnel. So we do see these with some regularity. Can present in infancy, but that's unusual. Usually it's kind of later adolescence or middle age, and a slight male preponderance in most series. That's the Finland information. So that's the Finland flag. I had a geography study on there, but I'm not going to give it to you. I had a flag quiz and geography study, but I'll spare you. It goes way back. There's an article reference from 1858, which we couldn't find it, but there's a reference floating around there. So people have been thinking about this for a long time. First case reported in 1858. The first surgical removal was Walter Dandy, one of the kind of pioneers in neurosurgery, through a transcortical transventricular approach. So going through the frontal lobe, getting into the lateral ventricle and removing it. People have also described aspiration, but comes back usually pretty quickly if you do that. And then endoscopic was first described in 1983. There's definitely a trend towards diagnosing this more frequently in asymptomatic patients, like just coincidentally, someone with headaches and a small cyst isn't causing the headaches. And that really can become a decision-making issue, which I'll go into a bit more. Most common presentation, obviously headache due to obstruction of CSF, nausea due to blockage of CSF, personality changes, vision, gait disturbance, or drop attacks. So that's kind of the classic symptoms. Most commonly headache due to obstruction of CSF. And on exam, some will have papilledema, gait disturbance, but a good proportion of them are normal. You may have upper motor neuron signs like Babinski incoordination. Nystagmus, I don't know I can't figure out the neurology of why you would have nystagmus with a colloid cyst, but people report it. So the elephant in the room here is the risk of sudden death from colloid cysts. So I'll go into a little bit about the potential mechanisms, but this is really where the decision-making and patient counseling comes in to be very important. So before CT scans, about 20% of the patients would present with just sudden death, just die, usually due to decompensated hydrocephalus or hypothalamic reflexes related to the third ventricle hypothalamus. And there are numerous isolated case reports and autopsy reports of this happening. So it is a thing. Review of the literature showed about 107 patients, and most of them are young. So these are patients that are before 30 years old. Most have a prodrome, about 80%, rarely positional. Common sense would tell you that it would probably be positional. You know, if you bent over or something, it would get worse, but it's not borne out by the literature. So headache, usually patients have a prodrome. So of these cases of sudden death, in the literature, there's about 2 days of symptoms before, and for kids even longer, up to about a week. And in the cases that presented with sudden death, the cysts are bigger. They're about 2 centimeters, you know, almost 2 centimeters. So those are bigger cysts for sure. So that definitely supports the idea that there's a mechanical obstruction at CSF leads to this. This is what it looks like pathologically. So this is kind of a bigger cyst. This one's probably at least about 1.5 centimeters. And that's the pathology again. I'll go into the anatomy in a little bit more detail, but this is the frontal horn of the lateral ventricle, frontal horn. The foramen of Monro would be here, and this thing is just blocking that all up. And this is cardiac muscle, so this is stunned myocardium related to increased ICP. So the thinking is a few pathways that could lead to sudden death. One would be, hydrocephalus, intracranial pressure, herniation. That's pretty straightforward, and autonomic instability. And the other one is kind of this Takotsubo syndrome, or the broken heart, the initial hypothalamic storm, with stunned myocardium, or even a necrosis of myocardium. So there's 2 main mechanisms, but really, I think most commonly it would be to acute obstruction of CSF pathways. Go into the imaging a little bit, and I'll give some examples because I think the imaging is interesting. It's not a uniform thing. The imaging characteristics can really be different. The one unifying thing, though, is location. So anterior third ventricle at the foramen of Monro. There aren't many pathologies that occur there. Colloid cyst is one. The other one that comes to mind is subependymal giant cell tumor, and tuberous sclerosis can also occur there, but usually that's off to one side. Central neurocytoma is another one that might occur commonly there. And there can be vascular lesions too. I'll show you an example of something that looked like a colloid cyst but wasn't. So here's just an example of what I was saying. So this is CT scan non-contrast, and you can see this calcified rim around this one. This one's a little more hyperdense, and then this one is like a little pea sitting there, calcified, one. So it can look, different on CT imaging. And then same on MRI scan. So here's an example of a pretty small cyst. This is probably sub-centimeter, but hydrocephalus. Here's one that is more calcified. You can see that darkness there. So the imaging can be variable. Here's a few more examples. Here's ones that this one almost mimicked like a little arachnoid cyst. It's isodense to CSF, little hyper intense here, but this would be hard to, you could miss this potentially, or radiology can miss this, but there it is. And you could mistake that for an arachnoid cyst. And here's another example of a smaller cyst with imaging characteristics different than CSF. So this is a FLAIR image, and this actually becomes important because this does help us differentiate which lesions are more likely to progress. So hyperintensity on FLAIR actually predicts progression. And here's another example of a hyperdense cyst with acute hydrocephalus, a big cyst about 2 centimeters. Here's one of the differentials that I was talking about. So here, this is a ectatic basilar artery with an aneurysm sticking up into the anterior third ventricle. So this is a differential that I would really be wary of and think about. But do that. So decision making. So I talked a little bit about the clinical presentation. So usually headaches, occasionally vomiting, protein signs of elevated ICP, personality changes, gait disturbance, these kind of things. But the sudden death thing really is a thing that patients get very concerned about, and rightly so. divide these patients into really two. One is the obvious ones where there's hydrocephalus, headache, vomiting, vision, or syncope, and big ventricles. So there, it's very clear, those patients need treatment and usually urgently, versus the asymptomatic patient with, vague symptoms. They got to scan for some other reason, smaller ventricles, and, colloid cyst may not be maybe like high riding and not blocking the CSF pathways, and an older patient. So those are the things that would push us towards non-operative management. So people have looked at incidental cysts. So there's meta-analysis here that ended up including 4 papers out of 134 screens. So that's a lot of work, of 176 patients with 5 years follow-up. And only about 10% of them went on to require surgery for clinical or radiographic progression. And only one of them had an acute presentation. So there's no sudden death. And most remained stable on imaging. So that's the takeaway is that you don't have to rush to do something on a patient that's asymptomatic with clinically discovered colloid cyst. Another one about the natural history, 162 patients followed for a mean of 25 years. Most remained asymptomatic, and these were smaller cysts. And over short-term follow-up, none of their patients had progression, but over longer-term follow-up, about 10% progressed. So that's an easy number to kind of hang your hat on, 10% over 10 years, no sudden death. But these patients were carefully followed and had routine imaging and routine clinical follow-up. Another natural history one followed. So this number seems to be about right. Almost about 10% will progress with observation. This graph talks a little bit about the size of colloid cysts versus symptoms. So there seems to be kind of a threshold about 7 millimeters, under which very few patients, if any, become symptomatic. But over that number, over 7 millimeters, then you start getting definitely more symptomatic patients. And even right at 7, you have symptomatic patients. This has become a number that I found useful in guiding suggestions for treatment. Again, assuming that they're not presenting with hydrocephalus, but essentially no patients are going to present with hydrocephalus with a small cyst. So very helpful. They also talked a little bit about location. So where's the cyst? So this is right at the foramen Monro. There are some that occur a little bit farther back and a little higher in this kind of zone 2 of the third ventricle. So this is a midline sagittal view of the third ventricle. This is the mammillary bodies. This is the fornix. This is the corpus callosum here. This is chord plexus of the foramen Monro. So most of them occur right here and cause obstruction. But if they're a little farther back and a little higher in the roof of the third ventricle, very unlikely to cause symptoms. This is an exceptional one. This is one that became mobile and obstructed the cerebral aqueduct. I think that's an extraordinarily exceptional case. This is the only picture I've ever seen of that in this paper. They come up with a kind of grading score. Is the patient old or young? In this case, younger than 65 is young, and I endorse that, versus younger than 65. Symptom of headache, yes or no? That's 7 millimeters that we talked about, and then the flare hyperintensity, and then also the risk zone. So the biggest risk would be a young patient with headaches, a cyst bigger than 7 centimeters with flare hyperintensity in the anterior third ventricle. So that would strongly push us towards treatment. And most of those patients will end up with hydrocephalus with a higher score like that. So this is the conclusions of their study. And I really endorse this approach. So 7 millimeter threshold, flare hyperintensity, young patient. These patients are the ones that we would treat. So surgical options, I'm a neurosurgeon, so we talk about treating these things. So the traditional is craniotomy. We also do endoscopic. We can do aspiration of the cyst alone, but this results in a high recurrence rate. If someone was a particularly poor operative risk, we could do just a shunt to relieve the hydrocephalus, but that's not something we generally do. People have also tried radiosurgery for this, but not something we do. So the craniotomy approaches, you can go transcortical, which is through the frontal lobe into the lateral ventricle. You can go transcallosal, which is through the corpus callosum, and then either through the foramen of Monroe or in between the fornices. That's a technically demanding approach. So transcortical is considered for cases with hydrocephalus, requires a corticectomy, which is an incision in the cortex. The thought is that there's an increased risk of seizure and hygroma after that. We can use stereotaxy, which is kind of GPS for your head, and we can use a small tubular retractor. This is just an example from prior chairman Pat Kelly, who did this with the laser. So this is the anatomy that we see for the craniotomy approach. So this would be an example of going through the corpus callosum and then seeing the foramen of Monroe here. So we're going interhemispheric, so between the two hemispheres this way. And then we can go dip into the lateral ventricle if we go laterally, or we could go in between the fornices. But the fornices are very soft. That's a technically demanding approach and really risks significant memory problems. So most people would advocate for interhemispheric, transcallosal, and then into the lateral ventricle here. And that's the view that we see. So this would be the fornix here. This is the choroid plexus going into the foramen of Monroe. The cyst would be here. The other approach that we can do is endoscopic. So we can just get into the frontal horn of the lateral ventricle here, pop in and get the endoscopic view. And I'll show a little bit of that. So here's an example of what we do endoscopically. This is a little catheter aspirating the cyst, and then we pull the cyst out intact in this case. I'll show some video. This is the equipment that we can use for that. So this is an endoscope. We have bipolar, we have dissecting things we can use. And this scope is that big, which is about 6 millimeters. So not huge, about the size of a pencil, but we can really get a lot done through it. And this is the view from the endoscope. So here we've popped into the right frontal horn of the lateral ventricle, and you can see very nicely, this is choroid plexus draped over the cyst. This is the cyst wall. This is little veins over the cyst. This would be the septum pellucidum here, and you can see it's thinned out from hydrocephalus. The caudate nucleus would be over here. This is the thalamostriate vein, which is an important venous structure. And this is what it looks like intraoperatively. We kind of buzz, cut, separate it out from the choroid plexus, grab it, and ideally pull it out intact. Not always the case. And here's a little video showing that. So here's our popping into the lateral ventricle. This is the septum pellucidum. It's quite thin. This is the cyst here. This is a monopolar. We're buzzing the choroid plexus over it. Using a little hook here. And I'll kind of move things along there. Oh, so here we're going to pop the cyst, make it smaller. We're kind of grabbing the cyst wall there, it pops. Sorry, I did this before breakfast, guys. And we're aspirating the cyst content. This is just a little suction. And now we're going to grab it. And there's some mucin. Here comes the cyst wall, along with little choroid plexus there. And the cyst is flat. Yeah, so there's some more content. Got to make it small before we can take it out. And you can see that kind of mucinous type stuff. More aspiration. Now we're grabbing the cyst wall. Yeah, not out yet. I don't want to belabor it too much. Okay, so there you go. Last little bit of cyst content. And then we're going to buzz the cyst remnants. Now you can see clearly into the third ventricle. This is the foramen, the septum pellucidum. You can see how thin it is from chronic hydrocephalus. And then this is just choroid plexus that's been buzzed. So craniotomy versus endoscopic, people have looked at this, a lot of cases in a meta-analysis. And keep in mind that a lot of these endoscopic cases are from early endoscopic experience. So what they're showing is a higher gross total resection rate with craniotomy and a slightly higher recurrence rate with endoscopic. Reoperation less than 1% or 3% for endoscopic. However, mortality lower in the endoscopic group, and need for a shunt actually higher in the craniotomy group versus the endoscopic group. So with time and experience, I think the endoscopic approach has definitely gained more acceptance and kind of is the treatment of choice in most centers. And people have looked head to head, craniotomy versus endoscopic. 30-day complication rate similar to procedures and reanimation, which was higher in craniotomy. So 14% for craniotomy, 5% for endoscopic. So from a lot of perspectives, the endoscopic approach is preferred. And here's just an example of post-operative imaging. So here's CT scan, MRI, and another MRI, and you can see the fornices here, cyst gone. Another one. So this is challenging actually. So this is one of the more challenging cases where you have a reasonably sized cyst and small ventricles because it's difficult to get access to the lateral ventricle reliably. So that's the kind of case we would worry about. Here's a case that had a little bit of bleeding afterwards, needed to leave a drain in, cleared and was fine. And here's just another example of post-op. So here's the cyst. This is a tough one. It's tucked up a little higher. It's a little bigger, small ventricles. Sorry, but comes out. And it's nice because it looks like nothing happened. All it looks like happened is we took out the cyst. You can't see a tract. You can't see any scar, anything. No hydrocephalus. Another one. And so these are just some post-op ones. We talked about this. So we can do it in small ventricles, but it's for bigger cysts with small ventricles, ones that we know are likely to progress or cause acute hydrocephalus. So we can do that even with small ventricles. It's just a little bit more technically challenging. So to sum it up, risk of sudden death is unknown, but it's likely low. Patients under observation need counseling. So if I have a patient with a colloid cyst who we're following, I tell them don't wait for 2 days to have headaches. Don't have headaches that whole time. Like if you have a headache on a colloid cyst, come on in, get a scan, get evaluated, make sure. And again, the factors favoring surgery: young, large, flare hyperintensity. In my opinion, the endoscopic is probably preferable. There's a slightly lower complete removal rate, but the complication profile is less and the costs are less. I'd like to end with a small advertisement. So I'm part of an endeavor involving a lot of people in the department. Neurosurgery, neurology were ranked #1 in the country last year, this year in U.S. News and World Report, and that comes through collaboration and cooperation. And I'm very proud to be a part of that department and all that we do here. I'm sorry I had to go a little quick, but I'm happy to take some questions if you have them.
Thank you, Dr. Harter.
You're welcome.
Yes,
Sure.
Brian and Ziska, neurology, professor of neurology. For the first time in about 25 years, I saw a patient with a colloid cyst 2 weeks ago at clinic. This was an older patient. He was over 60, who'd been having, he never had headaches, but he had a recent onset of daily headaches, worse on awakening in the morning, for about 2 or 3 months. More recently, he started vomiting even without headaches.
Yeah.
So we did a CAT scan. The CAT scan was enhancement, and the CAT scan showed a colloid cyst in the usual, I don't remember the size. So we immediately sent him to the neurosurgeon for evaluation.
Good.
The headaches were not really posturally related, although they did occur in the morning on awakening and gradually improved during the day. Do you have any comment on?
So I'd be interested to know if his ventricles were large, if he had hydrocephalus.
The ventricles were not particularly large.
Yeah, that's a
CAT scan.
Yeah, that's a difficult case. So if he has no hydrocephalus, small cyst, maybe incidentally has a different source of his headaches. I would look for papilledema. He probably didn't have.
I mean, I didn't measure the cyst, but I think it was around 7 millimeters. Or
yeah,
more.
so that's close. Without hydrocephalus, I might follow that patient. I'd have to see him. to really say, see the particular imaging, and I'd be happy to review it.
But if you have successful surgery, why not, especially with not a tiny one, but just a borderline one, 7 or a little bit more,
Yeah.
even without major hydrocephalus? I'd always thought the hydrocephalus was intermittent. It was
Yeah.
a ball valve thing.
Yeah, that's that's one of the thoughts. He hasn't had syncope or near syncope or anything like that. He has never passed out.
He did, I think, have one drop attack.
Yeah, so that's an interesting scenario. I'd be happy to see him if the other folks at your place have a different idea about it.
I mean, if it was me and I had this, I would have wanted removed, even if it's a 2 or 3%.
Yeah, right. Smart. Loss aversion. Good.
Good morning, Dr. Harter.
Good morning.
I'm Dr. Gary Peets Neuro. Thank you for a
Thanks.
wonderful presentation.
Thanks.
And I go back to the long time where we used to call this bobblehead doll syndrome.
Oh yeah.
Now, so they were all descriptive. And like Dr. Anziska mentioned, a lot of the times, we're focusing when it was intermittent. And when you were talking about the anatomy and the calcification,
Yeah.
a differential that I always entertain is craniopharyngioma.
Oh yeah, that's good. Yeah. Yeah,
And-
anterior third ventricle. Good. Yeah.
And, the endoscopic, when you're mentioning, we have come a long way, and otherwise all the other open methods, craniotomy, were a lot more, traumatic,
Yeah.
morbidity. So I'm happy, and thank you for taking care of all the children.
Oh, happy to. And I do have a few friends at Downstate. I have Dr. Pavlakis, who's traveling today, and Dr. Gustafson, who I also am friends with. So I have a lot of friends there, and I appreciate Brooklyn for sure.
And I come from the era of Epstein and Vissoff.
Yeah, Jeff
So,
is my partner, and
You
he's
know.
still at it. Yeah. He's doing great. Thank you.
So there's a question in the chat, Dr. Harter. I don't know if you can see it, but it's from Dr. Chari. The question is there a risk for chemical ventriculitis if the fluid from the cyst leaks out into the ventricle during the procedure?
Oh, good question. So we really irrigate quite a bit. So one of the keys in neuroendoscopy in the ventricle is that we irrigate very right. And if there's any question about either debris or blood from the procedure, we leave a drain in temporarily to get it out. So if someone comes in sick, I would also leave a drain. If someone came in acutely with a coma, I'd probably leave a drain in after doing the procedure to make sure that the pressure is okay.
Thank you.
Anybody else? Last chance. All right, Fatima, thank you very much.
Thank you, Dr. Harter. It was a great talk.
Appreciate you hosting. And again, I had to go a little fast, and I thank you. Feel free to, post a talk or make it available for whoever.
Thank you very much.
Okay. Thanks again.
Thank you. Have a good day.
Have a good day.